So, 3 years ago, we were asked whether a mid-Staffordshire could happen here in New Zealand. What was your answer? We participated in an ASMS survey over the past year to determine the level of burnout in the senior medical officer workforce. Can you remember the findings? Now, district health boards have two major functions. They are responsible for providing or funding the provision of health services in their district. They also have a responsibility as an employer to look after the staff they employ, including their health and safety. 3 years ago, I stood here and I spoke about burnout and compassion fatigue. In 2014, I spoke about building a joyful workforce. We listened to Dr. Peter Huggett speak on building resilience in the health workforce, and Tony Fernando spoke on the science of happiness. Maureen Bisnagu, the then president and CEO of the Institute of Healthcare Improvement, or IHI, she spoke at the 2014 APAC meeting and stated, "Joy is the key to providing the kind of care we want for our patients. Through joy, we gain the energy and resilience to do our jobs well." And that's an important concept because healthcare is tough. It is one of the most intellectually challenging, physically demanding, and emotionally draining professions there is. In 2016, the IHI have not forgotten the importance of joy in the workforce. Alongside all of its other activities, it continues with research, publications, and work to increase joy in the health workforce. A 713-patient study by economists in University of Warwick in the UK asked the question, does happiness make human beings more productive? They found that happy employers' productivity was 20% above the control group, and unhappy employers was 10% below the control group. Additionally, they found that individuals who are happier tend to manage their time more effectively, exhibit more creativity, solve problems more efficiently, collaborate better around common goals, and actually makes better leaders. Being happy and finding joy in your work is of the utmost importance, not just for your own well-being, but also for that of your patients and your employer. Is it important to you? More importantly, do you feel that it's important to your employer? So let me do a quick stock take. In the past year or so, what have we learned about the SMO workforce? At the 2015 ASMS conference, Dr. Charlotte Chambers presented her research on superheroes don't take sick leave. Over a period of 24 months, 88% of us went to work while we were unwell. Reasons for doing so included strong sense of duty towards our patients and colleagues, but also importantly, a lack of workplace cover for any unexpected short-term absences. Following that survey, we got the results of the burnout survey that showed that burnout is rife, with 50.1% of the SMO workforce indicating that they burnt out. This is a shocking result, and it should ring alarm bells everywhere. We also have evidence that bullying, sexual harassment, and inappropriate behavior is commonplace in our work environment. And later today, Dr. Charlotte Chambers will present her latest findings of her study on exploring intentions to leave the New Zealand public health workforce. I won't steal her thunder, and I don't know the results, so we'll hear what she has to say a bit later on. So what we've got at the moment is presenteeism, burnout, bullying, harassment. Not a very joyful picture, is it? You might rightfully ask, why do SMOs still go back to work? And I would like to give you some insight into the SMO culture and psyche. In the Declaration of Geneva, we pledged, "The health of my patient will be my first consideration." This is part of our patient-first culture, but it has actually become an increasing problem in the modern practice of medicine. Dr. Jim Cross, a retired emergency physician, was the keynote speaker at the Spring Representative Assembly of the Saskatchewan Medical Association. And he pointed out that the patient-first mantra can cause harm for the patient, because if we can't look after ourselves, we can't look after our patients. Brenda Senger, she's the director of the Saskatchewan Medical Association's Physician Health Program. And she points out, for physicians, the last area affected is often their work. They will give up their spouses, their children, their friends, their colleagues, their community involvement, their self-care, all of that. They will give up all of that, but they'll still go to work. Dr. Sam Hazeldine, the Queenstown doctor in New Zealand, he started a petition to add the following to the Declaration of Geneva. I will take care of my health and well-being so I can provide care of the highest standard. Dr. Stephen Child, NZMA Chair, has taken the petition to the World Medical Association's General Assembly in 2016, and you can still sign the petition online. So, burnout, fatigue, exhaustion, depression, illness, none of those stop us from actually going to work. We know that. What do we do to address that? What gives you joy in the work? I started off by asking what you answered when asked whether a mid-Staffordshire could happen in New Zealand. 3 years ago, my answer was unlikely. I actually want to revisit that today. To refresh our memory, the Robert Francis Inquiry examined the quality of care at Stafford Hospital that occurred between 2005 and 2009, and the many reasons why it was so bad, and it produced devastating conclusions. Once the shocking facts became clear, it had the effect of the proverbial frog being put straight into the boiling water. Everybody realized that what happened to patients and their families and what they endured was horrific and should never happen again. The then British Prime Minister David Cameron said 3 fundamental problems were highlighted in the Francis report. A focus on finance and figures at the expense of patient care. The attitude that patient care was always somebody else's problem. Defensiveness and complacency. David Cameron asked Dr. Don Berwick, founder and previous president of the IHI, to produce a set of recommendations for implementation in the NHS in England. Don Berwick summarized these recommendations as follows. Put the experience of the patient first. The patient comes first no matter who you are in the system. Hear the patient. Empower the voice of the people we are trying to help. They have more information than most anybody else in the system. Invest in the growth and development and capabilities of the staff, their ability to improve what they do and their ability to work together to improve what they do both within and across organizations. Take a big leap towards transparency that is absolute and complete. So what is happening in New Zealand at the moment? The ASMS, we keep highlighting the unmet health need. The Ministry of Health have acknowledged that there is a problem, but continues to be quite offensive regarding the extent of the problem. The ASMS helped funded Associated Professor Philip Bagshaw to research and investigate the true extent of secondary care unmet need. He delivered an excellent presentation last year at the 27th annual conference. He pointed out that our current system is designed to reduce the expectations that patients, communities, and GPs have regarding access to secondary care. There is a constant stream of reports in the media about patients being turned away and not receiving the care they need. Some of them go as far as selling their house to fund their surgery. It is not uncommon to read that patients are living with chronic pain, have lost their mobility and independence due to a lack of access to secondary care. The public and us have grown used to these reports. We have become desensitized. Figures now show that access to primary care has also become a major concern. The latest Ministry of Health survey reveals that 1 in 9 New Zealanders are not getting the care they need because of cost. That equates to nearly 500,000 people in New Zealand who experiences difficulties in accessing primary care. Now, the latest revelation is that patients are losing their eyesight due to delays in follow-up appointments. In response, the Ministry of Health said the average waiting time for ophthalmology treatment has reduced from 66 days in December 2014 to 59 days in August 2016. Health Minister Jonathan Coleman is reported to have said of the Southern DHB, they have got to do a lot better. He said that the eye specialist had not specifically raised this issue when they visited him. Are these comments patient-centered and transparent? It is with great concern that I read some of the explanations given for this year's adverse events report. An example, the Nelson Marlborough response, is reported by Samantha Gee as, the board says the jump in numbers is down to a new reporting system and improved staff culture, so people feel more confident about reporting events. Let me compare their response to the Stafford Hospital's initial response. Stafford blamed the increase in their mortality rates on coding errors. Don Berwick recommended a leap towards transparency that is absolute and complete. David Cameron highlighted defensiveness and complacency as contributing factors. In the words of the Health Quality and Safety Commission Chair, Professor Alan Merry, commenting on the release of the Learning from Adverse Events report, each of these very sad incidents has affected a patient, their family and whānau, and the health professionals who care for them. So let me get to the point. The public, the health workforce, DHBs, and the government have become desensitized to the unmet health need and the fallout from that. Desensitized to a system that is under strain and is underfunded. I have changed my answer to the question on whether we could have a Mid-Staffordshire here in New Zealand. I'm telling you today, we are having a Mid-Staffordshire here in New Zealand. It's just happening in slow motion. Unlike mid-staffs in the UK, we are slowly warming up the frog in the water, and it will eventually boil before we come to realize it. Before I point too many fingers, you might ask, what has the ASMS done so far regarding putting the patient in the center and to address concerns regarding the SMO workforce? We have created a path to patient-centered care. This can be seen and followed on our website. This includes excellent papers on the topic of patient-centered care, and this work is still ongoing. We have put a claim forward in our MECA negotiations, minimum standards for patient-centered care. This is still under negotiation, but the DHBs actually find this quite threatening. We have a new clause that has been agreed during current MECA negotiations, recovery time. Research done by the ASMS on presenteeism, burnout, and future workforce intention highlighted some of the problems that our workforce experience. We are actively working with DHBs through the JCC meetings to address burnout. If we cannot look after ourselves, we cannot look after our patients. We have highlighted workforce shortages in the articles in the specialist. We are concentrating on specialities with severe shortages. We hope to publish these as a health dialogue early next year. The ASMS, along with the RDA and DHBs, have been proactive investigating systems and solutions to reduce bullying, harassment, and inappropriate behavior. The ASMS has said for a number of years that there are entrenched shortages in the SMO workforce. We have and continue to warn that the system is under tremendous pressure and ongoing underfunding is contributing to this. We are not crying wolf. We are really concerned. So what's the way forward? I want to start by looking at lines of responsibilities. The public votes and determines who governs this country. The Ministry of Health is part of the government structure. The Minister of Health appoints DHB chairs. The DHB boards appoints chief executives, who in turn appoints managers and indirectly staff that delivers the service. So let's flip that around and put it in reverse order. You have managers reporting to chief executives reporting to DHB boards, who report through their chairs to the Minister of Health, who reports to the government, who is voted in by the public. It will come as no surprise that DHBs don't like staff talking to the public. That bypasses a lot of levels of reporting and a lot of filters. We should not forget the role of the Treasury, and I quote from their website. The Treasury provides advice to the ministers on the purchase and regulation of health services. The advice covers areas such as the structure and management of health spending, institutional and governance arrangements in the health sector, and health sector strategies and policies. DHBs do have explicit responsibility for providing or funding the provision of health services in their district and responsibility for the health and safety of staff they employ. However, we all have a role to play and decisions needs to be made. Everybody in the above chain has responsibility. Everybody in the system should put the patient in the center. So the way forward, advice to the public. Next year, you can exercise your democratic right and vote. Government, how are you going to spend your rockstar economy money? Reduce tax rates before the next election? Keep them the same and invest the money in the health service? Or should you even consider increasing taxes by 1 or 2% and ring-fence the money for health like they did in Scotland? Treasury, what is your advice going to be on the spending on health services? DHBs, are you going to keep doing what you're doing? Or is it time to start thinking that you're being set up to fail? Efficiency savings have been done and dusted. The fat and the low fruit has all been gone. You are still expected to do more with relatively less in a shorter space of time with an increase in quality and safety. You should do all that with staff that are increasingly unhappy and burnt out. That reminds me, you do have responsibility for the health and safety of your increasingly unhappy and burnt out staff. Workforce, continue to advocate for patients we see and treat. Continue to report from the front line. Get as much joy as you can from interactions with patients and colleagues. The system is running a bit low on joy at the moment. We have to get the heat out from under the frog. We have to take responsibility and achieve that. Thank you.